Dr. Deepti, welcome.
Hi, Shashi. Good to see you again.
Welcome, Dr. Deepti.
How are you?
Yeah.
So you're meeting Anup Singh for the first time. So I'll just kick off the session. So welcome everyone to this second Metabolic Health Conference of India, where we are showcasing some of the experts in the metabolic front, especially in the metabolic low carb, ketogenic, or carnivore front, in the space of metabolic management. So it is diabetes, obesity, but this time it's focusing more on the mental health, neurological health, cancer, and of course, diabetes has always been integral part of it. So Anup Singh is here. So Anup Singh, please give introduction about D Life.
Yeah, D-Life is basically I would say the largest and award-winning Indian low-carb platform. It started in 2014, and it was as a result of me being a diabetic since 2011, and till now I am not taking any pills. I'm surviving on low-carb, high-fat diet primarily, and my A1C has been 5.6 max all these years. So approximately 8 kgs of pills I have not eaten in all these 14 years. And as we progressed, as we evolved, now we offer, certification courses. So primary aim is to build an army of metabolic health coaches centered around low carb, high fat diet. That's about it. Thank you.
Thank you. So we too being the organizer of this conference. Welcome, Dr. Deepti.
Thank you so much.
So I'll just give a brief introduction about Dr. Deepti. Dr. Deepti Arora is an established and highly skilled physician with significant experience in the internal medicine geriatrics. So she's a gold medalist from Pune and has been trained in geriatric medicine from Christian Medical College, Ludhiana. She did her fellowship in diabetes and thereby pursued the advanced course in diabetes from the Royal College of Physicians, UK. Thereafter, she completed a post-diabetes from Royal College of Physicians, UK, a postgraduate diploma in clinical nephrology, Royal College of Physicians, UK. To further her knowledge, she is currently pursuing an advanced course in the management of diabetes and related disorders from the prestigious Harvard Medical School Executive Education Program. She is also founder of HealthWise Clinic, where she facilitates people to live healthy, possibly through a novel approach in the management of chronic disease like diabetes, hypertension, fatty liver, with innovative research-based intervention like therapeutic fasting, therapeutic carbohydrate restriction, customized eating habits, and other lifestyle intervention. With her empathetic and professional attitude, she has been regarded in the medical fraternity for her approach in diagnosing and strategizing the best customized treatment plan to treat chronic disease with positive lifestyle intervention and minimal medication. So, once again, Dr. Deepti, welcome to this conference.
Thank you so much, Shashi. That was, that remarkable introduction. I am also thinking, oh my God, wow. So, hi everybody. I am, as Shashi told everyone, I am Dr. Deepti Arora, and I'm a physician specializing in internal medicine with a lot of focus on diabetes management. I'm actually really passionate about finding ways to prevent diabetes and make sure that people stay healthy. That might mean helping them to lose weight with various methodologies. The methodologies once you have been hearing about in the 3 days of conferences, low carb and therapeutic carbohydrate restriction. So I do not, I would not ask somebody to refrain from using other strategies like losing weight. Some people who are very heavy, maybe 150 kilos patients I have, which we refer for bariatric surgery, and there are also weight loss medications which are being promoted these days. So ideally, weight loss is what the focus of managing diabetes and the chronic decisions. When I'm not working, you'll find me reading on the ancient health texts, the ancient seers who have written about how to lead a healthy life. You'll find me reading about those and how we can use it today. I'm excited to connect with all of you and share about health and diabetes management, whatever I have learned in my short experience.
I think I'll mention that Dr. Deepti is practicing in Chandigarh, India.
Yeah, I'm in Chandigarh.
Yeah, Anup.
Yeah, Chandigarh, India, which has got, I think, highest percentage of diabetics, if I'm not wrong.
Yeah, no, you're absolutely right. Chandigarh, India is the diabetes capital of the world, and Chandigarh is the diabetes capital of India.
Okay, Dr. Deepti, it's always a pleasure, interacting with like-minded doctors. When I say like-minded, means they are practicing low carb, by and large. So being a, mainstream doctor, what made you enter into this low carb or TCR, as an option to be given to patients?
So, as shared by you, it was basically my own personal experience which started it. And as a diabetologist with a family history of the disease in the family, I knew I could not afford to overlook the warning signs. So I was in my own, body, I was having those warning signs of gaining weight. And then I had to polyuria, polydipsia, all those were there. So I found myself at crossroads. I was very clear that I don't want to be a diabetic. The fear of succumbing to the same fate as all those people, it was a dark cloud. So with the support of my friend, I shed around 14 kilograms and witnessed a remarkable improvement in my blood work numbers. It was a moment of triumph, actually, that fueled my determination to chart a new course, not for myself, but my patients as well. Guiding my family through the same journey wasn't easy. As a trusted family member and a healthcare provider, I felt the weight of responsibility on my shoulders. I couldn't afford to falter or let them down. Despite the doubts and fears, I pressed on. Delving into research on therapeutic carbohydrate reduction, I armed myself with the knowledge and insights that would allow to revolutionize my family and my practice. Advising my patients to embrace a low carb lifestyle wasn't about managing their diabetes. It was about empowering them to reclaim their health and vitality. But as you all are aware, the road ahead was fraught with challenges. Skepticism and raised eyebrows greeted my unconventional approach, but I refused to waver. As the word spread of my patients' remarkable transformations, my practice flourished. The trust they placed in me was humbling, and they started calling me a doctor who removes insulin. I was grateful for this opportunity to make a difference in their lives. Today, as I reflect on my journey while talking to you, I am really filled with gratitude for the lessons learned, for the challenges overcome, and the changes that I have been able to make and touch lives along the way.
This is really very impressive. I mean, uh, any doctor who will discontinue insulin is going to be a god for the patient.
So actually, in Chandigarh, they call me doctor who removes insulin. They'll come to me in Hindi and they'll say, "हमने सुना है आप insulin हटा देते हो." So that is, a every time such a patient comes, it's like a pat on my back. Okay, fine, and I feel proud that I've been able to help them. And
And I
I've
think
had patients who are taking insulin on maybe 4-5 times a day. And my success story is removing a patient of insulin who was on more than 100 units of insulin.
we call them industrial dose of insulin.
Yeah.
So I think for the viewers, the clarifying factor here is what Dr. Deepti says is it is in type 2 diabetes patient, not in type 1. So in type 1, insulin is required. What she means is in those patients who are not controlled adequately with nutrition and they have been pumped with a lot of insulin, and she helps correcting the nutrition, the baseline, and helps either lowering or removing insulin. So there's a caveat which I wanted to add.
Yeah, thank you so much. Yes, type 1 insulin is where type 1 diabetes is where your body is not, making insulin. So how I put it across to my patients is that when they make their sabzi or dal, whatever they're eating, if they forget to put salt, they add additional salt. So that is type 1. Body is not making insulin at all. Type 2 is a different opposite condition. It is hyperinsulinism. Body is making excessive salt. So when the salt in the dal is more, they have to put something to remove that salt. So that is how I explain to my patients.
Very crucial point to touched upon very nicely that type 2 diabetes is the condition where we produce excess insulin. I
Excess
think
insulin.
this requires an underlining of it.
Yeah.
Now, doctor, what is wrong with the current system in the sense a lot of starchy foods are actually recommended? How harmful it is? What is the consequence of these, especially in the diabetes population when they eat a lot of starchy carbohydrates?
Yeah. So mainstream recommendations they're not accepting low carb approach right away, but yes, changes are happening. However, I would also like to point out that mainstream has never focused on refined starches like white bread, white rice, sugary cereals. They also have always asked to consider the glycemic index of the starchy foods. However, things have not panned out the way they were supposed to be. And when we talk about the long-term effects of taking such starchy foods, there is a lot of things that we have to consider. So if we are loading up on refined starchy stuff like white bread, sugary cereals, and processed snacks, the first and major effect is on the waistline. These foods are packed with calories and they're very low on fiber. So it is easy to pile on the kgs. And we know that carrying extra weight isn't about how we look, it's about our health too. Obesity can lead to all sorts of issues like diabetes, heart disease, and even some cancers are now known to be caused by diabetes. Oh, sorry, for obesity. There is a whole lot of then the blood sugar roller coaster, which we have been talking about. When you're munching on refined carbs, the blood sugar levels shoot up fast, which means the body has to pump out more insulin to deal with it. Over time, this leads to insulin resistance and sets the stage for type 2 diabetes. Our heart health takes a hit too. Diets high in refined carbs can mess with our cholesterol levels. They ramp up the inflammation in the body. Subclinical inflammation also goes up. And another thing that they do is they send the blood pressure soaring. There is growing evidence also now that such diets may be affecting our brains too. Fluctuating blood sugar levels can mess with our memory, with our concentration, and with mood over time. These diets are also not nutrient rich. This means we end up on missing out on various vitamins, various minerals, and antioxidants that our body needs to stay healthy and strong. Therefore, choosing whole, unprocessed options keeping an eye on the portion sizes also can go a long way in keeping us healthy.
Very nice. So one of the processed refined carb which is recommended practically to every diabetic is the ubiquitous Marie biscuit.
Yeah. And the protein powders.
Yeah, so we always have this joke that it is always said that Marie biscuit is very safe for diabetics, and they take, and when you say safe, when you recommend only two, they will finish 2 packets because
Right.
they think it's safe. Now coming back to this, we know that low carb option is there in the MNT of ADA right from 2019, or the consensus report of ADA ESD from 2018. Diabetes Canada also from 2020 has adopted. Diabetes Australia, it is there. And now recently, you know that Diabetes Australia has tied up with Defeat Diabetes and included low carb as one of the best practices. With
Right,
all
right.
these, there still seems to be very reluctance in promoting low carb for diabetes, whether it's type 1 or type 2, irrespective, at least for type 2. Why there seems to be so much reluctance still?
So I'll add on to this. Diabetes Sri Lanka and Diabetes UK have also added on looking at TCR. And it's kind of puzzling. Even though now they know that low carb is the way forward, they're still not, low carb diets are still not getting the love that they deserve from the mainstream community. And I think, this might be also to do with the fact that for years together, we have been told that low fat and high carb diets are the way to go. The message has been hammered into us for so long that it's hard to shake off. It's like trying to convince someone that the sky is not blue. It's like going against everything that, for generations we have learned. So it is going to take a little time. Then I think there's the food industry. They have a big say in what we get on our plates. And guess what? Carbs are cheap and easy to mass produce. It's no surprise that food industry has been pushing carb heavy products for years. But now I think the tide has started to turn. As you pointed out, ADA is also in its guidelines in 2019. Diabetes Canada, Diabetes UK, Diabetes Sri Lanka, they are starting to accept that low carb might be a good for us. They are seeing the research, and the good thing is hearing the success stories, which you people like you, Anoop, and everybody else, individual, they might call it anecdotal evidence for now, but they've started to look at it and they're starting to pay attention. Still, debate will continue, and at times they might have a point because, to be very honest, in a population like the Punjab population, if we tell patients to go on high fat, so the amount of ghee that they consume is not funny. I have seen it practically. So if you tell them to go high fat, it's like adding 5 tablespoons of ghee to their, dal. Or so there are pros and cons to both the situations. There are cases where we have seen keto and diet-induced pancreatitis and other complications. So this debate is going on. But I think at the end of the day, it is all about finding what works for you and what works for the entire population. There are people in whom I think low carb diets don't work, but for most people, they're a game changer. And as more and more folks start to realize that, I think we'll see low carb diets become more mainstream. I think it's just a matter of time, and we patiently have to wait for the tide to turn. And with people like Anup, you, and the entire community, I think it'll happen sooner than we expect.
Anup,
Yeah, Dr. Deepti, carrying on from what Shashi said and what you said in your answer, doctors like David Unwin, Dr. Gary Fetke, they were very open-minded to say, we are sorry, we have been, treating patients wrongly
Right.
by pushing this industrial, I would not call it, standard American diet. It's basically industry push diet.
Right.
Now, do you think that this takeoff of low carb in India is because some doctors or many doctors are not willing to say sorry? We have been teaching you or feeding you wrong. We made a mistake, let's correct it. It's as simple as that. So do you think is it that way?
See, again, there are two sides to the coin. One, of course, accepting your mistake and moving forward is, according to, I would say, you, me, would be the right approach. But on the other hand, there are some doctors who would, counteract it by saying we've not asked the people to have burgers and pizzas and all those refined carbs. We are asking, we have been insisting on whole grains, everything. So there has been a lot of, mismatch which has been happening. So expecting a senior person, a qualified person, a person who's been practicing in the same way for 30, 40 years to say sorry is, I think, expecting too much. People who can come and do it, it's hats off to them. But yes, on the overall, if I see, there are doctors who are accepting this approach. We meet a lot of doctors in our conferences, in our meetings. So I see them going off carbs at least at the conference at where we are. So the tide is shifting, as I said.
Okay, so now you said, talked about Punjab, if you tell them to eat ghee. I would like to add one point to that point, putting ghee on both sides of roti does not make it LCHF.
Yeah, of course.
Right? So this I've been saying since long, I don't know, maybe around 10 years. Now coming
Okay.
back to question, what are the challenges that you face from the patient when you tell them to, switch to low carb or, transition to low carb? And what all diseases, are associated with diabetes you commonly see in your practice?
So, Anup, as you have, and as a doctor, I can say that managing type 2 diabetes in India is like a wild adventure. One of the biggest love affair that we have is the love affair with our carbs. So,
Right.
if I tell you, in any patient, if I tell them, it is very difficult for them to resist a plate of piping hot rice or maybe fresh paranthas in Punjab. So it's a very, very difficult journey because it is such a big part of our culture. And speaking of culture, you will also agree with me that vegetarianism is a big here. Lot of folks like to opt for veg-based diets. They don't want to take meat-based diets. So the reasons are many. They're religious, ethical, and you name it. We've got a lot of reasons. But even I try to tell them, even veg foods can mess with your blood sugar if you're loading up on starchy stuff like potatoes or refined grains, especially refined flour, maida, which we use so often in our diets. So it's all about finding that sweet spot between carbs, protein, and healthy fats. Then there's a whole, India also has a challenge to access to healthcare. Assessing the right healthcare can sometimes feel like navigating a maze, especially here where it is, very limited, and the doctor patient ratio is significantly dependent on the location where the patient is. So again, it is not about medication only, it is about having a reliable support system in place, which will help you navigate the complexity of managing diabetes. And we cannot ignore the lifestyle factors. With the pace of modern life, it is very easy to fall into sedentary habits and rely on convenience foods that are available at the easiest. It's super easy to get sucked into a vortex of Netflix binges and takeout dinners. But staying active and making smarter food choices, oh my God, that's a big challenge and a different ball game altogether. Encouraging people to stay active and make better food choices can be an uphill battle. And I see it every time, it is very difficult to ask them to move, especially in a city like Chandigarh, where we have ample parking. In a city like Delhi, people have to walk maybe to the metro they have to take the stairs. Chandigarh, ample parking is available. There is no need to walk. Even though there we have a lot of green areas, everything, people are reluctant. Then, as for the diseases which are associated with diabetes, there is a laundry list. Heart disease, high blood pressure, stroke are the big ones. And the next comes with is the major, now the upcoming epidemic, which is supposed to be, that's fatty liver, NAFLD, non-alcoholic fatty liver disease. Kidney disease is also another one. So then there comes neuropathy, which can cause numbness and tingling in your hands and feet. There are so many people who have that burning feet syndrome, where they feel their feet are burning. Retinopathy, which can lead to vision loss if not caught on early. And apart from all this, let's not forget about the mental side effects of things. There's unfortunately too common in people with diabetes is depression. So either that may be related to the mental fog that carbohydrates are causing, or it may be related to their body image and body shape. So lot of complications, and it is not only one system which is affected. From the, as I pointed out, from the head to the toe, every organ gets affected.
So, Dr. Deepti, there are a plethora of drugs available now of late. Earlier, there was only sulfonylurea, metformin, maybe some glitazones, some insulins, but now we have plethora of drugs in the last 1 or 2 decades with introduction of DPP4, SGLT2 inhibitor, GLP1, and even now imaglimin is also available. So with all the availability of so many drugs, are we still able to get adequate control in these patients with diabetes, or is it still off the mark? If so, why?
So I'll give you a data which is Shashi, which is pan India data. In a diabetes population, the average HbA1c throughout the country in patients who are approaching clinics and having regular follow-ups, the average HbA1c is 8.5. So this data, it's alarming. And yes, as you pointed out, there are a lot of medications available. It's an incredible time. And as a practice means, my practice 10 years back, we had only 2-3 medications. And now I have almost a list of so many medications in which I can put my patients on. But question is, do these medicines actually help getting patients good control? One, in our country, cost is also a big inhibitor. Right, GLP-1, I cannot put every patient on GLP-1, even though I have seen remarkable results with GLP-1 myself. So to give you an example, a patient of mine who tried low-carb approach for 2 or 3 months with an HbA1c of 13 could not manage even 1 kilo of loss. So I ultimately had to put him on a GLP-1 agonist. Within 2 months, he did not lose, even on GLP-1, he did not lose weight. But his HbA1c dropped from 13.1 to 8.0. So as a doctor practicing, I would say at least the harm that the high blood sugars are doing, that is being controlled, even though the weight loss did not happen. So many of these medications work in, various ways to lower the blood sugar levels, help in weight reduction, and mitigate diabetes-related complications. When used appropriately and in conjunction with other lifestyle modification, they can help the patients go a long way in achieving their treatment goal. But when we combine medication with low-carb approach, there is a right balance that we have to strike. Adopting a low-carb approach enhances the efficacy of the medication and maybe even reduce the higher doses that we have to constantly put up the patients on. As all of you know, if a patient strictly follows a low-carb diet, medications can be off. I have also done in so many of my patients. There are so many patients who are, maintaining remission for a long time. However, on the overall, that's only a 5 to 7% of the population who can stick to such a strict regime for the rest of their lives. Some or the other reason for the rest of the population, they want to go back to one bite of cake for their son's birthday, or one bite of prasad when they go to the religious temple or the Gurudwara. So ultimately, 95% requires some degree of medication, but that is also related to the duration of the diabetes that they've been having. In my own practice, I will recommend a low carb approach, and if the patient cannot deal with totally a low carb approach, I will often recommend a safer medications. Today, the SGLT2 inhibitors that you talked about are proven to be safe for the kidneys and for the heart. So I would do not shy away from using that. Some patients definitely with the long-standing diabetes benefit more from medication, while most people find success when they focus on intensive diet and lifestyle changes.
It
Ultimately,
is very
our aim
interesting.
is to empower these patients to take charge of their health. Now, whether it is medication or a low carb approach, or if I have to push them to at least work out, at least 30 minutes of work, 40 minutes of work, I try to do all that.
Yeah. No.
Yeah, I think you mentioned the average A1C was 8 point something, right?
8.5.
Now, that's not surprising because whatever data that we have on community, there also we compiled, I think, for 50. The average is somewhere around that much when they started. But yes, we were targeting 5.6 max as the end target, because we don't believe in the term pre-diabetes,
Right.
because that's a misnomer or a cruel joke by industry on diabetics. Anyway, now you said you recommend medicines along with diet, and medicines, of course, in certain cases where diet alone fails.
Yeah.
Perfectly fine. So with this approach, I would ask you how many of your patients, get down to 5.6 or maybe 6.5 as internationally it is called remission sort of. So as a percentage of total number of patients that you see.
So, Anup, thank you for asking that question, because when we discuss the pan-India data, and when in my OPD, I use software which can compile all the data. So when we were talking about this pan-India data in the latest conference that it is 8.5, I analyzed my patients, how many patients were in remission and how many patients were, still off mark. So I would like to say, out of the younger population that I deal with, and younger population I would say is below the 60 age mark. So anywhere between 35 to 60, I have been able to get an average HbA1c of 6.0%. I have
Okay.
not calculated 5.6 per se, but at least, my aim has always been below 6.0. So it may be 5.9 or 5.6. I have not analyzed that. But yes, a lot of them are there. And in the older population, my benchmark is 7, because if they have been having diabetes for, let's say, about 30 years, for 20 years, there has been a degree of beta cell failure which has happened. So even if they lose weight, even if they go into remission for 3, 6, 9 months, maintaining a long-term remission for them, because at that age, at 70, 80, 85, I have patients, my youngest patient is 94-year-old diabetic. So at that age, asking them when they're finding, changing their cultural beliefs and not eating, so that's a little difficult for them. But at least if they're maintaining around 7, I'm very happy. So most of my patients, young patients, are in the range of below 6, and the elderly ones above 70 to 95 are below 7. I'm very happy with that.
Yeah, that's perfectly fine because, as you
Or-
deal with older patients, they would say, Abhi kitni zindagi bachi hai, kha lene do. Right?
Right.
This mentality comes in.
Yeah, and somewhere in our country, cost of feeding them also impacts.
Yes.
You can't ask a 90-year-old who's depending on his family to have a high protein and eat twice a day. That cost has to be seen. The family dynamics has to be seen. The environment has to be seen. And so all that keeping into mind. So it is, I do not have a very stringent approach that this is what I want. 5.6 is the cutoff. No, I take it to each person's individualized and, environmental approach.
I think it's remarkable. 6 on an average
Yes.
is
Very
remarkable.
remarkable.
And
Thank you so much.
unparalleled in many cases. With whatever approach you're approaching, a moderate approach with a safer pill, which may not cause hypo, and using all this good. So, one question I want to ask, one question it vexes everyone from a medical doctor point of view is, why is the incidence of diabetes rising in India? People say कि हम हमारा दादा नानी कहानी always comes, nana nani kahani, they were eating the same thing, why it is coming, what could be the reason from your perspective?
Yeah, so like you said, dada dadis, first, definitely it is the genes. So one thing which I tell my patients is, if suppose my patient X, Mrs. X is a diabetic at 52 years, so I encourage them to control it at there and then, so that their next generation can say that there is no genetic influence in my family. Right. So that is my first point, that do not go for genetics. Genetics is there. It is 10%, 90% is your lifestyle. If you control your lifestyle, you will not pass on to your further. So don't do it for yourself, do it for the next generation. And we Indians, we have a genetic predisposition. We are thin fat Indians. We are not obese like the Americans. We will hardly see come across a patient who's 200 kgs. We are generally around the 90, 100 mark. So then there's a lifestyle. Now there is a lot of, at least in the urban areas, there's a lot more processed food, sugary drinks sitting around more than ever. Advertisements of those Sting and all those drinks, is there. And with this urbanization on the rise, the overall globalization happening, the westernization happening to our culture, we see a lot more people swapping home cooked fresh meals with convenient and Swiggy options. And the obesity epidemic is going to it's means difficult. It is, our culinary habits also play a big role. Like I said, Punjabis, you can't go tell them to have as much ghee as they want, because I've seen those meals, the ghee floating on their dals and sabzis. Not on, they'll say, we roti mein to nahi lagaya, as Anu pointed out, but dal and sabzi, it's floating. So the food is definitely, we are, as a generation, as a country, we are heavy on carbs more than, other option. And cost, as you were discussing in the previous section, carbs are cheaper. Most of our Indian population cannot afford the right kind of fat, the right kind of protein. So carbs are their go-to option. So that is why the incidence and the prevalence of diabetes is very high in our country. The people who can afford, they have a lack of awareness. The doctors also have a lack of awareness. Access to healthcare is, not exceedingly high. And then there are screening programs. The government, even though they are emphasizing on screening, the fact that people acceptance that I can have diabetes, I am gaining weight, is very difficult. So screening programs and will go a long way in diagnosing the problems early on. So when I see a patient who's newly diagnosed with an HbA1c of 10, had the screening happened 5 years ago or 2 years ago, he would have been caught on early and treated accordingly. So those are also, it's a mixed bag. But addressing these factors through education, lifestyle changes, we can really make a lot of progress in ensuring that India does not stay the capital of the world, diabetes capital of the world.
Anup?
Yeah, I'll combine two questions into one. Approximately how many patients in your practice, I would say annually, do you see with TCR implemented? And can you talk a few of your memorable cases where the success is beyond belief?
TCR, as in, you mean
Therapeutic
patient?
carbohydrate restriction.
No, I know. But patients whom I treat on TCR, is that the
Yeah.
question? 100%
Yes.
of diabetes.
Yes. How
My
many numbers
recommendation is
per annum?
100%. Number per annum would be around, maybe I would say around 4,000 patients per annum.
Per annum.
Yeah.
So that's 10 patients per day, roughly.
Sorry?
That's 10 patients per day.
More than that, yeah. So yeah, so I am taking of around 15 if I put an average. So that number of patients and multiplication, doctors are bad at math. So around 4,000 patients and annually I'm seeing, which I'm encouraging them to restrict their carbohydrates and take care of their diets. And trust me, many patients, if you go in a stepwise approach, like my approach to a patient who's on 5 meals, maybe like the earlier advice, 5 small meals, I would first ask them to stop snacking. I would say you take 3 meals, and one of those meals should be 0 carbs. Means either you have only eggs in the breakfast, no bread to accompany your omelette. So that is one. Second, I will not switch your roti, or I will not shift your, of course, rice, I tell them, and starchy vegetables, I tell them to remove. But my mainstream is first meal, you go off carbs. Then when the patient, I call them after 1 month for follow-up, is comfortable with that, then I will switch the carbs off at night also. So it's basically one carb-loaded meal in the lunch and two meals which are maybe one is egg-based or protein-based and the other one is vegetable, salad, sprouts-based. So that is a kind of approach which I'm dealing with, and this has gone a long way. And my memorable cases, my God, I have so many of them. I can't be taking my patient's name on a public platform. So let's call one patient Mr. Rajesh. So Rajesh was 45 years when he was diagnosed with type 2 diabetes. And this was a newly diagnosed patient. And as I said, newly diagnosed screening had not happened before 45 years of age. His HbA1c was 10.9 and elevated triglycerides. So concerned about his health, he came to me and decided to take action. What we did was at that level, 10 plus HbA1c, I did not want to wait for the TCR and his habits to change and to kick in and then wait for 3 months and then see the change in his. So I put him on the SGLT2 inhibitor. So that SGLT2 would not let the high sugars cause a further organ damage. And also the discussion with him was that medicine will be only till the time he achieves remission. So with encouragement over a period of 2 months, he also, decided to make a change. He's adopted a total switch to a low carb diet, focusing on the good proteins and the healthy fats. He incorporated, luckily for me, he incorporated physical exercises, aiming for at least 45 minutes of exercise, which was sustainable for him in the long term. Over a period of 6 weeks, he was able to gradually reduce his medication. And he could afford, so we had put a CGM also. And his sugars were 98% of the time, they were time in range. So time in range that we call is 70 to 180, but my level of time in range is 70 to 150. So ideal, the recommendation is 70 to 180, but I tell my patients, your postprandial should not peak above 150. So he was able to be in time in range for almost 98% of that time. And after 3 months, his next HbA1c reading was 5.6. By sticking to this habits and, he also was committed to his health goals, he has now reversed his diabetes and he has been on no medication, what we call remission, for the last 3.5 years. He has been very active and the only thing I told him was to get his weekly fasting sugars checked so that we can, if it comes back, we can catch it early, and also to keep an eye on his waistline. So weekly waistline measurement has to be done for him. So those numbers he keeps in check. And apart from that, I don't think I've seen him for diabetes for the last 3.5 years. Another patient has been a very memorable patient was basically my first patient. She, let's call her Priya. She was on 124 units of insulin. So she's a 52, when she came to me, she was a 52-year-old person, very scared about, and as a female, her scare was, I have to see my children get married and I have to see my grandchildren. So that was the motivation point for her. And slowly she started to incorporate low carb in her diet. Total vegetarian, no protein, no meat, no egg. So that was a challenge, how to get her off insulin. So again, with her, working with her, I learned that, I can put her on, 2 meals. So I brought her down from 6 meals, snacking every time, Mary biscuits and all that. I brought her down to 2 meals, restricted her time window from, I told her that after she finishes her household work, from 11 o'clock to 6 o'clock, she can eat. Apart from that, she's only going to have water. So, and she also, very diligently cooperated with me. She adopted those lifestyle changes and started to notice positive results. Because she was on high doses of insulin, she has a lot of hypoglycemic incidents also. And her, daughter used to, before starting all of this, her sugars used to fall at around 40. And while sleeping at 2 a.m. And at 2 a.m., her family used to check her blood sugars, that is she sleeping or is she, comatose? So that was the condition. So when she switched her diet, she noticed that hypoglycemia episodes started to, they were not there. Together, slowly, we were able to work and reduce her insulin doses one by one. It took a year, 124 to, coming down to zero HbA1c, maintaining that. It took almost a year, I think 9 to 10 months it took. But even today, after I think 5 years, she continues to follow her low carb lifestyle, small eating window, restricted eating window, TRE as we call it. And she's very happy with her progress. So these patient journeys, I think, will highlight the lifestyle interventions that we need in managing diabetes and improving overall health outcomes.
And that's very amazing because you are one doctor who's combining the best of all, the best of medication and lows and the best of dietary practices. So whatever you are reaching where they are.
Yeah. So my point is, see, everybody, you cannot put everybody in one same, we are, and like I tell my patients, God did not have a mold where he, put us, and all of us do not come with the same metabolic health. So it is a customized, individualized approach where I have to see low carb may not be sustainable for one because of the religious belief or the cost effective. So somewhere means I try to draw a balance where these patients, ultimately my aim is to have a diabetes complication free life. So diabetes is there, okay, fine, but maintain it around 6, have zero rate of complications. That is what I aim for. And when they overshoot that goal, when they stick to the lifestyle and come to me with a report of 5.6, trust me, I am the happiest person.
Now, very important question. Did you ever face pushback or criticism?
Oh, lot of it. From my own colleagues, from, so my worst criticism was a patient of mine recommended his friend who's a surgeon to me. So that surgeon, I will not take the name of the surgeon, renowned surgeon in the city, 120 kilos approximately weight. And I started him on TCR. And his point was, I have to stand all day. I need between surgeries, I need to have a sandwich. So I counseled him. I worked with him for maybe around 6 months, tried my best what I could do. And then he went back to some other doctor who was practicing the conventional approach, and told him this all is all fad, it will not work. So I think that has been a disappointment coming from my own community, a person. But yes, there have been other doctors who have been my friends in my medical college who have been able to reverse their diabetes. So that's okay.
Anup, since
Yeah,
we are
just
coming
as
to
I
the end
said,
almost, yeah.
just as I said, to say sorry we were wrong, it takes a lot of courage, and that's unfortunately missing, at least in India. Let's hope that this changes for the future with doctors like you, providing evidence and ground up approach, because top down it won't work. So all the best and thank you for coming. And
Thank you
we'll
so
have
much for
more.
having me.
Want to
Yeah.
ask you, what is your message to India through this platform?
See, my message will be of empowerment and hope. I want to tell people you are in charge of your lives.
Right.
Diabetes is a significant health challenge with the rate of prevalence that we have, but it is not insurmountable. By coming together as a community, as both of you are doing commendable work, we need to teach people to embrace healthy lifestyle choices and prioritizing preventive healthcare and early intervention. And with all this, we can turn the tide against diabetes and its complications. So I would want to make India a diabetes-free country. And if not a diabetes-free country, at least I want to ensure that it's a diabetes complication-free India. So I do not want to see patients with CKD, with eye disease, with neuropathy. So at least a complication-free India is what I would like to have, at least in my
Just one
lifetime.
point to add, you mentioned about that patient takes on 125 units of insulin.
Yes.
Now, 125 units of insulin would be around about, I think, 250 per day. That is including the cost of consumables,
Yeah.
right? 7,500 per month.
Yeah.
Anybody with a, sense of calculation and dedication can do low carb, in that 7,500.
Of course, I agree. But again,
So
that
it is not
message,
costly. It is
yeah,
not costly.
and anything is not costly if it costs you your health.
Right.
So I tell my patients, go, if I may say it in Hindi, I tell my patient, अंडा खरीद लो, डॉक्टर को पैसे क्यों देना है?
That is right.
है ना?
Thank you.
Thank
Thank you,
you.
doctor.
Thank you.
So we hope to meet again and have good collaborations with each other so that we can help more and more people in this country. So thank you very much, Dr. Deepti, and we look forward again. Thank
Yeah,
you.
looking forward, and it's so nice connecting with all of you today.
Bye-bye.
All the best for your
Bye.
endeavor.
Thank you.